Hi guys, this is Steven. Welcome to this crash course video on the pathophysiology of visual field defects. So in this video, we'll be covering what visual field defects are, the anatomy of the optic tract, the pathophysiology of visual field loss and cranial nerve palsies, and some tips for the clinical examination and history. And then we'll be finishing with some multiple choice questions. We'll also be starting with these questions, however we'll go through the answers properly at the end. So question 1, what type of field loss is this? Take a moment to pause the video and answer these. I'll explain why it is this field loss at the end of the video. So question 2, how does a cranial nerve 3 palsy present? And the third and final question, an abducens nerve palsy affects which muscle? Okay, so what are visual field defects? So visual field defects are loss of part of the visual field. The visual field is anything that can be seen at once, and in terms of the degrees of which you can see, you can see 50 degrees superiorly, 60 nasally, 70 inferiorly, and 90 temporally. So the visual field is formed by the optic nerve's sensory input into the occipital cortex of the brain, and it's sort of like a relay center. So to start with, we'll look over the anatomy of the optic tract in order to clarify how the visual field's formed. So this diagram I made earlier in order to illustrate the visual field. So we'll start off with the visual fields. So as you can see, the left side of the eye sees the right part of the visual field, and the right side of the eye sees the left part of the visual field. This is an important fact to keep hold of for later use, because it's very important when it comes to the pathophysiology. So in terms of the actual anatomy, the optic tract consists of the eye, the retina, the optic disc, the optic chiasm, the lateral genicular nucleus, and the optic radiations, which transmit the information into the occipital lobe of the brain. This pathway integrates the sensory function of the optic nerve and allows the occipital cortex to identify and process the visual information experienced by the individual. So to put it simply, it allows us to see. The key thing to note is how the temporal retina is uncrossed and does not decussate, and the nasal retina is crossed and does decussate. So remember it as the acronym TRUNC. Temporal retina uncrossed, nasal crossed. This is very important when it comes to visual field loss and identifying where the lesion might be. So again, the reason why is because, again, as the left part of the eye makes up the right visual field, it's important to have all of the sensory information from the left part of the eye together. So you've got the left part of this eye coming in here, and the left part of this eye coming in here. So as you can trace the colours back, you can see that all of the information for each visual field is on its equivalent side. So again, the left part of the eye sees the right part of the visual field, the right part of the eye sees the left part of the visual field. So hold on to this fact. So now we'll move on to discuss the pathophysiology and causes of lesions and field loss. So in the following slides we'll discuss lesions of the optic tract and associated field loss, as well as some causes, cranial nerve palsies, causes and associated symptoms. So to begin with, we'll take back the picture that we just had of the anatomy of the optic tract, and we'll go through some lesions and what type of field loss that they'll draw up. So to start with, number 1. So number 1 will cause this type of field loss. Here, as you can see, both fibres which make up both parts of the visual field are being damaged, and you'll get this type of visual field loss called a left anopia. The next lesion is in the optic chiasm, and as you can see, it's damaging both of the nasal retinal fibres. So it's damaging, if you trace back where these fibres see, you can predict what type of field loss you get. This is called a bitemporal hemianopia, but it's also known as a bipolar hemianopia. So to reiterate, because of the lesion's location, you'll get loss in both of these nasal fibres, which see the outside of the visual field. So just, if you're ever confused, just trace back where these fibres are coming from, and you can predict what type of field loss you'll get. So the next lesion, number 3, would give this field loss, which is called a right homonymous hemianopia. So this is important because remember the fact we discussed before. The left side of the eye sees the right visual field, and the right side of the eye sees the left visual field. So after the optic chiasm, where the nasal tract decussates and meets the temporal tract, this integrates all of the sensory information for the opposite side of the eye, right? So if you had a lesion here, you would lose all right-sided vision and thus get a right homonymous hemianopia. So the next lesion, number 4, is here in the optic radiations. Now this is a bit different because, as you can see, it's not affecting both parts of the retinal fibers. So in the optic radiations, you have upper fibers and lower fibers, superior and inferior. So the superior fibers, which we'll say these ones for the sake of argument in this diagram, they provide the superior field of vision for that side, and the inferior fibers provide the inferior field of vision for that side. So in essence, if there's a lesion on the upper fibers, you will lose visual field in the upper part of that side. So here, remember, we're on the right side of the brain, we're on the right side of the eye, so we'll get visual field loss in the left field, and then the type of field loss will depend on whether it's an upper fiber or a lower fiber that's being affected. So here, it's a lower fiber, so you get visual field loss like this. So just to go over that again, the upper fibers, which we'll say are these on the outside, provide the upper part of the visual field for that side of the eye, and the lower fibers provide the inferior part. So if you just have a lesion in just the lower fibers, you'll get lower visual field loss, and you'll get this sort of pattern. So this is called a left homonymous inferior quadrantanopia, which is a bit of a mouthful, but that's the way it's described. So the next one, number 5, this would be sort of the opposite. So number 5, remember, it's on the left side. So you get field loss in the right part of the visual field. And then remembering that 4 was an inferior fiber, 5 is a superior fiber, so you get superior field loss here, which will illustrate itself like this, which is a right homonymous superior quadrantanopias. So the superior and inferior quadrantanopias occur because of the locations of the lesion. Again, we'll discuss some of the causes for this in a moment, but we'll finish off with one more type of field loss just to help illustrate it. So number 6. Number 6 is in the upper fibers on the right side. So if number 4 is an inferior quadrantanopia for the left, then number 6 must be a superior quadrantanopia. And thus, the visual field loss you'll get is this. So just to go over some causes, number 1 could be caused by a meningioma of the optic nerve, causing full compression on one side from the meninges. Number 2 is anything affecting the pituitary, because if you think of the anatomy of the pituitary gland, it sits above the optic chiasm. So any sort of tumour, any lesion, any sort of aneurysm could compress the optic nerve in the optic chiasm and thus cause the bitemporal hemianopia. And then for number 3, any lesions of the retrochiasmic tract, so behind the chiasm, could cause the right homonymous hemianopia that we observe here. So it could be an embolus, it could be a stroke, it could be anything of that sort. And then just to relate to the quadrantanopias, they could just have vascular causes, so occlusions or bleeds. Again, it could be seizures, and it could also be trauma to this part of the head. So next, we'll be going over some cranial nerve palsies. So there's 3 main palsies to be aware of. Nerves 3, 4, and 6, oculomotor, trochlear, and abducens. They present in such a manner, and I've made a few little diagrams to illustrate this. So to start with, a third nerve palsy. So in a third nerve palsy, the affected eye would have an eyelid droop, they would complain of diplopia, and they would get downward deviation of the eye. So the way I remember it is 3 symptoms, it's the third nerve, and they all begin with the letter D. So diplopia, downward deviation, and droop, which would present as such. The next one is a 4th nerve palsy, which is quite a subtle palsy to recognise because the 4th nerve provides the superior oblique muscle. So the only time you would be able to observe it is when they activate the superior oblique, which would be looking downwards and inwards in this position. So as you can see here, the eye has not fully intorted and it's not matching the other eye. So they would complain of vertical diplopia. They would have a compensatory head tilt away from the lesion, and it would be very, very subtle to try and find. And then finally, a sixth nerve palsy. So in a sixth nerve palsy, the sixth nerve affects the lateral rectus muscle. So in the affected eye, they would fail to abduct the eye. So here, the medial rectus will be pulling this eye inwards, but the lateral rectus will not be mirroring this movement, and so the affected eye would just stay still in the midline. So a key pathophysiology of this is idiopathic intracranial hypertension, because due to the excess fluid accumulation and the pressure within the brain, there would be compression of the abducens nerve. And this patient would complain of horizontal diplopia, so double vision only when looking left and right. So now to talk about the clinical examination and the history. So key points to remember is the cranial nerves exam, do the double H movement, and ask the patient if they get any diplopia. If they do, where do they get it? Is it vertical? Is it horizontal? Then test the visual fields using either a neurotip or your finger. Bring your hands in slowly. If they do have any loss of peripheral vision, it's your job to map it out, and by doing so you can identify what type of field loss they have and therefore the cause. So remember, if they do have a problem, bring your hands in slowly, because then you'll be able to accurately plan out the loss. So then observe the eyes again and watch attentively and see, does the patient have their head tilted. So in terms of features within a history, the patient may be complaining of injuring themselves by dropping things. They may have suddenly become clumsy. They may also complain of double vision, either when looking up or looking left or right. And in idiopathic intracranial hypertension, it's usually a young female with recent weight gain, and it's therefore a sixth nerve palsy as well. That's the features that you'd see on examination. So just some tips for the OSCE, a summary of the key points if you will. Watch their eyes closely. Watch their face. Do they have any droop in their eyelids? And when doing the double H movements, make the H quite large so that you can really test the full range of motion. And then also test their peripheral vision. If there is any visual field loss again, move it in slowly. So now to come back to the questions and what have you learned? So question 1, what type of field loss is this? So think of the type of field loss. What side of the visual field is it on? Is it nasal? Is it temporal? And what does it correspond to in relating to the optic tract? So the answer is a bitemporal hemianopia, because you get loss on the opposite sides of the eyes. So therefore, it's in both temporal fields only. So it's a bitemporal hemianopia. So the next question. How does a cranial nerve free palsy present? So think of the visual symptoms and the action of the cranial nerve free. So would it be nystagmus, confusion, clumsiness, pruritus, tinnitus or a reduced smooth pursuit, papilledema, transient headache on cough, diplopia, downward gaze deviation and droop? So the answer is D. Again, remember, nerve free, 3 major symptoms all beginning with the letter D. So diplopia, downward deviation, droop. And then the third and final question. An abducens nerve palsy affects which muscle? Is it the superior rectus muscle, the superior oblique, the lateral rectus, or the medial rectus? So remember your cranial nerves and the functions. So the answer is the lateral rectus. So I remember it in the mnemonic SO4, LR6, EE3, meaning superior oblique, 4th cranial nerve, lateral rectus, 6th cranial nerve, and everything else, 3rd nerve. So then that marks the end of the video. Thank you for watching. I hope it's been useful.